All right, tough following a presentation with cute babies, pictures and images, but I'll give it a shot. My name is Robin Shook from Children's Mercy. I'm going to share some findings from our Lauren Aronson Pilot Award. Here is the grant information. We have a very long title, Translating Clinical Care to Public Health Practice, a targeted approach using electronic health records to inform community health in a pediatric health system. This was definitely a team science project. Myself, I'm an exercise physiologist with training in public health. My co-investigator is Emily Hurley. She is, among other things, a social scientist. Dr. Colvin is a practicing clinician. And Christopher Harris, he's a community member who runs a park over in the Ivanhoe neighborhood. And we also had, I want to also acknowledge other members of Dr. Hurley's team who helped out with the project. Dr. Nick Schutz, who's back there somewhere, and he did the lion's share of the analysis and manuscript development here, and then also Dr. Ross and Lynette Larney. Okay, so prior to me joining Children's Mercy, the program that I direct, Kansas City Healthy Lifestyles Collaborative, received funding to launch the 1, 2, 3, 4, 5 Fit-tastic initiative. This was essentially a project to create community clinical linkages to promote lifestyles that are associated with a healthy weight in pediatric populations. So it was centered, ultimately, it was developed around with the name 1, 2, 3, 4, 5 Fit-tastic. So each of the numbers represents a lifestyle practice that was associated with a healthy weight. So obtaining 1 or more hours of physical activity per day, 2 hours maximum of screen time per day, 3 servings of low or non-fat milk or yogurt per day, 4 servings of water, not sugary beverages per day, and 5 servings of fruit and vegetables per day. This was funded by the National Institute for Children's Health Quality, and it was one of, I believe, 7 across the country that were funded. And this framework is not necessarily new. A lot of the evidence aligns with several other national initiatives like Exercise is Medicine, which you heard Dr. Esterbrook talk about today. And just from Exercise is Medicine, this is actually their clinic provider handout that they talk about the importance of assessing physical activity as a vital sign within the healthcare setting and documenting that level of physical activity in the electronic health record. So the public-facing campaign of 1, 2, 3, 4, 5 Fit-tastic involved a lot of messaging and consistent imagery that we could send out into the public. And ultimately, 218 organizations between about 2013 and 2018 adopted some sort of the messaging that we developed. So you can see some handouts related to, let's see if I can get, is there a laser pointer? Will the laser pointer work? Yeah, there you go. So here's a handout on screen time. Here's a handout on dairy consumption. Here is a clinic office that has all of the 5 components, lifestyle factors on the wall. So the idea would be that you would see these messages out in the community, and then you would also hear about these or ask about them when you take your child to their pediatrician's appointment. We also had a great website. It's still active with all of these resources that anyone could download and get more information on. The actual questions themselves are in this form right here, and we don't have time to go over it today, but there is structured questions around each of the 4 lifestyle factors. So the idea is everyone would use the consistent question format, both in communicating with the families and asking about the behaviors in a clinic setting. So the program itself was actually quite successful based on the pre-designed metrics. So we were able to integrate the questions and the responses in the Children's Mercy electronic health record. As I mentioned, it was adopted pretty extensively within the community, with over 200 organizations adopting the messaging. When you went to a well child visit, over 90% of the time, these questions were asked of the families. We got lots of publications out of this. We were able to leverage the momentum behind the project to new initiatives like the healthcare sector of the Kansas City Physical Activity Plan. And it was also well received nationally and internationally. So from our perspective as the team that was administering the program, we considered this a successful program. However, we also knew that there were some things that could be improved. So there was definitely a missing connection to community resources. So if you're in the clinic and you find out that a child is not getting enough physical activity, all we had available was like a handout on how to get your kid more active. There was no referral to community resources where they could join a sports program or something like that, or access healthy foods. So that was something that was missing. Additionally, there were institutional leadership changes within the primary division that was administering these questions within Children's Mercy. There's also extensive turnover of providers within the division. And so the value of the assessments versus the cost of completing the assessments was becoming diminished. So we tried a variety of ways to help out the division, to address their concerns. Ultimately, it led to the development of this application. So we were originally going to support the strengths and address the opportunities for improvement within the clinical setting. That was our specific aim 1, and specific aim 2 was to design a public-facing search and referral platform for community programs. That was, we received the funding in August of 2022. It took a few months to get IRB set up and other logistics to get in place. We were about ready to begin, and then 2 weeks before the start, General Academic Pediatrics within Children's Mercy, the primary division that was administering these questions, they stopped asking the questions. So we quickly had to pivot because we didn't have anything to assess. So we decided to change the specific aim 1 to identify the essential elements of a future pediatric primary care-based healthy lifestyles assessment, and then kept specific aim 2 as is. So for specific aim 1, just due to time, I'm going to skip over this, but we had two phases of assessment. So we did initial information gathering with in-depth interviews with the healthcare workers within Children's Mercy. We had a focus group of bioinformatics professionals at the hospital. We had a focus group of parents and caregivers, and then we also had a focus group of community providers. We developed main themes based on those initial information that we collected, and then we aggregated them and created recommendations in the form of an implementation survey, which we then sent out to healthcare workers within the hospital and asked for their feedback. So essentially, we were trying to figure out, what do the healthcare workers want? What are technical considerations around this? What do families and caregivers want from this type of a system? What about the community organizations? And then at the end, how do we put all of this together? For specific aim 2, which was developing the referral platform, we partnered with the University of Missouri-Kansas City Midwest Center for Nonprofit Leadership to do this aim. And we realized pretty early on that the food access database already existed in multiple formats already. So things like Lift Up KC or findhelp.org. Those resources had quite a bit of information on how you could access healthy food options. So we focus exclusively on creating a physical activity database. So we essentially tried to count every single physical activity program offered within the Kansas City region through a variety of methods that I don't have time to talk about right here. So I'm quickly going to go over the results for specific AIM 1. And so these are some of the selected data from our healthcare surveys and interviews. And the first thing you'll note is when we ask people in general how important it is to ask about physical activity and nutrition within a clinical setting, 94% think that it is either very important or somewhat important. So even though these questions were dropped from the clinic flow, that doesn't mean that providers thought that they were not important. So there was something else that was explaining why they were dropped. In terms of how do we think what do providers think is the best way to assess this information? 20% thought the original 5-question screener that was previously in the clinic was the best, where 38% thought that a more conversational style was the best approach to asking about physical activity and healthy eating. And then in terms of where this should be documented, should it be documented and where it should be documented, over 60% thought it should be documented in the electronic health record, essentially exactly how we had it set up before, with preset fields where you could click exact specific amounts for physical activity and food consumption. Others, there were some that also thought that you should do it more in like a comment style format. In terms of some selected comments from the interviews, we'll start with the nurse practitioner. In terms of asking about physical activity and healthy eating, I think it's more meaningful to have a conversation than to use a questionnaire. In terms of how you then refer people to outside resources, I can advise and they can decide. I'm comfortable sharing my concerns about their decisions, but ultimately I respect their decision. And then more on the referral process, the more we can have our staff engage and help patients and families walk through the resources, the higher chances we will have an impact. When we're talking to families, there were some really nice comments. In terms of assessments, I think the non-judgmental part is very important because then that can make the difference between someone decides to take a referral or not. And both of these comments essentially get at things have to be close to where the families already are. If it's specific to my neighborhood, that would be different versus a long list of, say, pantries throughout the cities. I'm not going to go through that. I'll come back to some of those comments when I wrap things up. In terms of the physical activity database and referral system, we have a full technical report that is 85 pages long, I think, and I'll show you how to access that in a second. But essentially, we counted 3,399 youth physical activity programs offered by over 500 unique organizations within a 6-county area around Kansas City. I could spend a whole hour talking about just the things that we found here, but there's a lot of information that we collected around all of these systems in terms of both the volume of systems and the types of services they provide. We created a public-facing database where anyone can access this information, and that's at kcsportsdirectory.org. So you can type in anything you want, like soccer, baseball, dance, swimming. You can also click on the search here, and it'll give you a full list of all the programs. You can also search specifically by sport type, programs just for boys or girls, by zip code, cost, and age. So what are the next steps and summary? I'll do the next steps first. So we currently have a manuscript under review. Hopefully that'll be accepted in the next month. We've shared this information with Children's Mercy clinicians and providers. And we've also disseminated this information at lots of national meetings, and we're presenting in the next couple of weeks actually to the Exercise is Medicine Pediatric Special Interest Group. But unfortunately, adoption within healthcare settings, either at Children's Mercy or other healthcare settings, has not occurred as of this date. So, quick summary of what we identified, and I'll start here on the right. Just in terms of logistics, we found early on that resource databases needed to be available, publicly available, and up to date. So we had that for food access, and then through AIM2, we developed the physical activity database. In terms of time, that was a significant barrier. Both the screening itself within the clinic needs to be time efficient. There's a lot of demands on clinicians, and the referral process within the clinic needs to be efficient and sustainable within the existing clinic workflows. And then in terms of accessibility for families, resources, both in terms of the cost of the activities and how feasible it is to access via transportation, needs to be a high considerations for family. And so this is one of the quotes. It was on a previous slide. You may have saw it earlier, but I'm a bus rider. After I get off work, I'm not going to go anywhere else. If I want to get healthy foods, I'd have to take off work to go there with my kids, and I'm just not going to do that. So they need things that are close to where they're at. So future directions from this work, whether it happens here or at other healthcare institutions, assessment needs to be seamlessly implemented in a non-judgmental way within a clinic. There needs to be some formal collaboration with all of the programs, whether it's youth physical activity programs or food access programs, to identify diverse resources where families can find them in a location-based way. And there needs to be continued support, likely through the clinic or a social support within the clinic, to continue to adapting recommendations to evolving needs. So here is a QR code if you want to find any of the references. Some of the images that you saw were part of handouts. We created 2 infographics that are intended for lay audiences that you can access here, in addition to some of the other publications I mentioned. And we're a little past time, but I'm happy to take questions if you want to delay your lunch by a few.
Thank you. There it is. Questions. Let me go back here and I'll come back. Okay.
Hi, that was great, Robin. I had a question about the locations you tried to implement this in. Did you go to like the ICS group of providers outside of Children's Mercy to see if you could get it in more of the frontline pediatric instead of here at Children's Mercy?
That is a great question. We submitted a letter of intent to do exactly that, to obtain additional funding to focus on integrated care networks. So, for example, my pediatrician is not at Children's Mercy, but they're on the plaza, and so, but they're integrated with Children's Mercy. So we did view those providers as a great next step for implementing this type of work. So we are trying to find funding to do that right now.
Wonderful talk. Thank you. For the example of the mom that said after work she doesn't want to go somewhere else to get food, I'm assuming the same mom would say, I don't want to travel somewhere else to take my kid to a exercise class or something, or a football game. So, and also there are, there's going to be kids that are just not interested in team sport maybe
Correct.
or more. Did you develop pamphlets or information for here's 4 15-minute activities that you can do at home, exercise, jump rope or something like that? And is 1 hour enough a day to actually make a difference?
Yeah, great question. So to the last part, the federal government recommends physical activity for children in the amounts of 60 minutes per day of aerobic activity. So based on the evidence-based, 60 minutes is sufficient for children and adolescents. In terms of the other question, I briefly mentioned this, or maybe I skipped over it, but as part of the Fitastic framework, we did develop handouts, educational handouts that could be provided through the clinic and just through other settings as well about how to get physical activity within your home or non-sport-based physical activity. So we have those available as part of the original initiative. Yep.
Any other questions? Oh, yeah. We are about 5 minutes into lunch, but I think we have some time.
I was just going to ask, I was working over in Columbia, Missouri, whenever Fitastic was kind of rolling out, and we implemented this as a community initiative and also within the clinical setting. So I'm curious if you've maintained contact with the clinicians over at University of Missouri Clinic. They've done some research from the provider perceptions of implementation of the clinical tool, if they've maintained that implementation. And then also, I was at the health department at the time, and we were implementing kind of a motivational interviewing approach where it was a telephone-based kind of that kind of navigation, as well as kind of supporting the parents just in general in helping their kids get more physical activity or whatever it was on a one-on-one basis. So I'm just curious, if you guys have maintained that conversation and connection over with the folks over there.
Yeah, it's a great question and comment. There were a handful of other providers and health systems across Missouri, and even there was one in Minnesota that adopted it, believe it or not. And Dr. Sarah Hampel, who really led the development of the initiative back in 2013, she still maintains collaboration with the University of Missouri partners. So yes, there is some connection that I know that they just published a paper within last year or so on this work. Yeah.
All right, thank you so much.